thanks to Maria and Kathy and Ilan Bashuti who asked me to do this. Can you all still hear me if I kind of talk right over here? Is that on the mic? Okay, great. So I'm talking about kind of ocular chemical injuries. And again, if people have questions as I'm going through, please just either raise your hand or yell out, and I'll try and answer them. I don't plan to go the whole hour, so I'm happy to answer questions either in the middle or toward the end. I do have some financial interests with companies I work with. The only company that's even marginally related is, I will mention, Restasis, which is made by Allergan. I'm going to start off with 3 questions, and I won't give you the answers now, but at the end of the talk, we'll go over these questions again and go over the answers. So regarding chemical injuries, which is true? Acid injuries are more common, but generally less severe than alkali injuries. Alkali injuries almost always cause severe vision loss. A white eye on presentation is a good prognostic sign. Or it is safe to use steroids in the initial treatment of chemical injuries. One of those statements is true. Question 2. Upon arrival of a chemical burn patient to the emergency room, which of these statements is true? An extensive history should be taken. The vision should be checked immediately. The pH should be checked before irrigation, or irrigation of acid injuries should be done with a mild alkali, and vice versa. No, we'll go over it later. Last question. We'll do the answers at the end. Treatment of a chemical injury, which is true. Amniotic membrane should be considered early in the treatment of severe chemical injuries. A banded soft contact lens should be used in all eyes with epithelial defects. A paracentesis and washout of the anterior chamber significantly improves the prognosis for severe alkali injuries. Or permanent keratoprosthesis works well for corneal scarring after chemical injury. Okay, again, we'll go over those at the end. So chemical injuries, why are they important? Well, one of the reasons they're important is that they're rather common. As Maria said, an emergency room such as Will's sees chemical injuries all the time. Young males are at especially high risk, but certainly anybody can get a chemical injury. They can occur at home, things like car batteries, pool cleaners, detergents, bleach, ammonia, drain cleaners, can all kind of fly up into the eye. It also occurs in the workplace. Caustic materials, caustic chemicals, solvents, some materials aren't so terrible, but then the high pressure actually causes extra damage. Then it can also occur in assaults. It's always kind of big news in certain countries, India being one of them. People attack others with drain cleaner. Just a terrible, terrible thing. In fact, there was a New York Times article just this weekend looking 30 years later at a person who was attacked by some Drano many, many years before. Epidemiology of chemical injuries is that they account for around 10%, look at different studies, 7 to 17% of all ocular trauma. Alkali injuries are more common. It's one of the questions I asked earlier, are more common than acid injuries. Things like ammonia, lye, potassium hydroxide, lime, which is a component of cement or plaster. But certainly acid injuries are not rare. Sulfuric acid comes in cleaners, car batteries, hydrochloric acid. Hydrofluoric acid is the most severe of the acid injuries because it's got this low molecular weight that penetrates very easily and rapidly into the cornea. Chemical injuries can cause a wide spectrum of corneal problems, from mild ocular surface damage, just mild SBK with literally a mild chemical injury, doesn't cause, it can be scary, but doesn't cause anything really significant, all the way, the range all the way, to blindness or losing the eye. Let's see, is this my pointer? So this patient over here, some mild haziness, vision pretty good, not so terrible. Needless to say, this patient here, pretty terrible result. The severity of a chemical injury depends on many different things, including the type of the chemical, so acid or alkali, strong acid, strong alkali, weak alkali, the degree of penetration, and some of that has to do with just the volume that gets in, the force, and the type of chemical that it is. The surface area of exposure. If it's just a small area, just inferior, it's going to be not as bad that if a chemical gets in the eye completely. If it's a little bit more solid, it may be more localized. Liquids often go over the entire eye, although tend to be more inferior than superior just because of gravity. The time of exposure. If a chemical gets in and stays in for minutes and minutes or hours and hours, it's going to cause more damage. If it gets in, it gets washed out within 10 seconds. And, of course, the management of the injury helps, but as we'll see kind of toward the end, some injuries are just devastating no matter what you do to them. But certainly, with appropriate management, we think we help the prognosis, at least in many patients. Whether the chemical has been under pressure also kind of can add to the injury and also to add to the extent of the injury in the eye and also add just to the damage and penetration that they get. And there may have been combined with a thermal injury. This may have been a hot chemical, so just the heat will do damage. And sometimes it can become like a molten metal type of thing, which is not really a chemical, but kind of comes in that same category of injuries. Let's talk about acids for a minute. Not as common as alkali injuries, but these are low pH. They generally cause less damage than alkali injuries. What happens is the acids kind of precipitate and denature and coagulate the corneal protein. So it hits the cornea, and it basically forms a barrier, kind of solidifies, forms a barrier, which decreases further penetration of acid into the eye. So acid injuries tend to be less severe, more surface, but less internal eye damage, less kind of severe eye damage. Having said that, strong acids in high concentration can be blinding injuries that no matter what you do, the eye goes down the tubes. So just because it's an acid injury doesn't mean it's going to be mild. This is a battery acid injury. So you can see this. What I show this is kind of, there's precipitates there. So the epithelium has kind of become white, the conjunctiva has become white, and that precipitate actually prevents kind of acid from further penetrating. Alkali, high pH. The problem with alkalis is they raise the pH of tissues, causing saponification, which is just a fancy term for turning the corneal proteins into soaps, and the alkali then gets easily through these soaps into the back of the cornea, into the anterior chamber, iris, lens, and potentially into the back of the eye. And that happens within seconds of a severe alkali injury. And the inflammation, therefore, you just can go deep into the eye. Here is a concrete injury, which is an alkali, relatively superficial injury. You can see there's an epithelial defect there. That's actually been healing over a couple of days, not a terrible one. Now this one here, you can see that there's this area of blanching down here, where there's an epithelial defect on the conjunctiva and an epithelial defect here with haziness. Not the worst injury in the world, but certainly pretty significant alkali injury. And there is just a bad alkali injury. Okay, it just basically melted the entire front of the eye. Now again, I'm going to reiterate that all chemical injuries can cause damage to the superficial and to the deep blood vessels. And it's really the blood vessels that bring the nutrients to most of the parts of our body. And when the blood vessels are damaged, it causes ischemia, lack of nutrition, lack of oxygen, and this ischemia causes inflammation. And that'll be important when we talk about some of the treatments for these chemical injuries. Inflammation is the accumulation of white blood cells, destructive enzymes. So the more inflammation there is, the more damage there is to the ocular structures, the epithelium, the cornea, the conjunctiva, the sclera, and the inside of the eye. Okay, on to treatment. Okay, the emergent treatment of a chemical injury, probably not telling you anything you don't know, is irrigation of the chemical out of the eye. Whether it's at the work site or at home, the first thing to do is to irrigate the chemical out of the eye. Ideally saline, water is fine, but basically most non-toxic liquids will do. If you've got some Gatorade there, that's all you've got, don't spend 10 minutes going to the sink to get water. Put the Gatorade in the eye. That's not going to do any harm. What you don't want to do is kind of look for an acid to neutralize an alkali injury, and an alkali to neutralize an acid injury, just creates heat and causes other chemical injuries. So you don't want to do that. You just want to irrigate, ideally with saline, water, Ringer's lactate, something like that is the best emergent treatment. Once you've done your irrigation, okay, or just prior to find this chemical injury, you take a brief history, chemical injury, okay. Check the pH so you know what you're dealing with. You want to know where you're starting. If you're starting off with an acid or an alkali, you want to know that, and you want to know kind of where you're starting. If you're starting at a pH of 10 or 9 or 8, it's different than if you're starting off at a pH of 7.5 type of thing. You want to know where you start so that once you've done your irrigation or during your irrigation, you can recheck the pH and figure out whether you're gaining or not. And then the rapid irrigation, copious irrigation. How much is copious? Well, I looked at a whole bunch of different books and papers. No, there's no right or wrong answer, but basically several liters. How long? Well, maybe 30 minutes would be reasonable. Then stop, wait for about 5 minutes to allow things to equilibrate. If you irrigate, and then check the pH 2 seconds after you stop irrigating, well, of course, the pH is going to be 7. That's what the saline that you put in there is. You wait 5 minutes, recheck it, and basically you want to irrigate until the pH reaches about 7, about neutral, 7, 7.5 perhaps, but basically 7, and then that's when you want to stop. What if it's still 8 after 10 liters? You're doing it for 3 hours. I mean, there's no real rule to that, but that's probably enough. You may want to keep the eye open with a lid speculum. There are some actually irrigating systems that have a speculum built in with a little cup that goes right to your IV solution. It doesn't really matter how it's done as long as you get this copious irrigation in. There's always a question of, do you want to do a paracentesis, where basically put a needle in the anterior chamber and suck out the aqueous. Theoretically, boy, if I've got alkali in that aqueous and I suck it out and I put saline in, I'm going to be improving the pH of the aqueous, which is probably true for about 3 seconds until the alkali that's in the cornea and the iris and everything around just goes back into the anterior chamber. So the answer to paracentesis is probably not worth it, because you probably can't, unless you can do continuous aqueous paracentesis washout for hours and hours, which you don't do, then it's probably not worth it. And if the pH is remaining abnormal, you need to think, well, maybe there's a piece of concrete or something in there that's just leaching out chemical, and that's why the pH is not normalizing. So, you need to lift the lid, flip the lid, look all around, double evert the lid like with a DeMar retractor, and make sure that you've got either necrotic material out that's just kind of holding on to this chemical, or you've got any, again, cement, debris, lime, whatever in there. I remember seeing a patient as a resident maybe 15 years ago in the cornea clinic, days and days after they'd been seen in the emergency room with an injury, and was poor healing, couldn't figure out why. Finally double everted, and there was a big hunk of concrete up there that was now embedded in the conjunctiva. They actually had to cut it out with scissors, couldn't just peel it out. And then once we got that concrete out, the cornea healed within a day or two. So you really need to think about that if the pH isn't coming back to normal, or if it's not healing. And once irrigation has been done, or kind of during the irrigation, take more history. Important things to know in the history are the location of the injury, home or work. Unfortunately, these often end up as legal cases, so lawyers will come to you and say, where did this happen? And now the patient told you it happened at home, but now they're telling their lawyer, oh no, this happened at work, with my boss watching me, and therefore I need to get paid for everything, and that may or may not be true. You want to know the type of chemical, the force of the fluid, was it solid, was it heat, all those other things, and then were they wearing eye protection? Just something good to know in the chart. And then previous treatment, did they get irrigated, did they get chemicals, what happened before they got to you? And then you want to document your findings. You start off with kind of any external. Some of these chemicals can cause severe damage to the skin, the eyelids, the face, even the rest of the body. But certainly you want to document anything that's going on the face. And then corneal and conjunctival exam. Cornea, what's going on? Is there an epithelial defect? Is there stromal loss? Is there actual ulceration there? And then an important thing is, how well can you see the iris? How clear is the stroma? What's the stromal haze? Because that will help us determine kind of the severity of the injury we'll go into in a minute. Limbal blanching is another very important aspect of the initial evaluation, because it deals directly with prognosis for chemical injuries. Limbal blanching is how much kind of whiteness is there at the limbus? Where are those blood vessels damaged at the limbus? Anterior chamber reaction, important, and do they have a cataract already? Has this alkali gone in and actually caused the lens to become white? Okay, so here's an alkali injury. There's fluorescein here, and you can see the fluorescein is kind of picking up a lot of area there, but looking okay over here. Okay, so there's no epidefect here, but there's a huge epidefect. The entire cornea is an epithelial defect, and a lot of the conjunctiva is an epithelial defect. But you need to look all around. Where does that epithelial defect end? Well, basically the whole globe, but the lower lid conjunctiva looks pretty good here, which is important because that's where the epithelium will come in to cover the eye, the bulbar conj, and then the cornea. You're looking over here too. There's the extent of the epithelial defect. So this is good epithelium over here, which is nice because you've got some good starter cells that are going to come and grow over. And there's just with cobalt blue light, just to show, again, good conj here, but big epi defect in a lot of other areas. That's all the same eye with a bad alkali injury. So there are several different classifications of how do you categorize the severity of a chemical injury. And I'm going to go through two, the Roper-Hall classification, which is a little simpler, and then the Dewar classification, which is a little bit more complicated, but we'll kind of go through those quickly. Grade 1 is there's damage to the epithelium, but no limbal ischemia. Pretty mild in the grand scheme of things, chemical injury. Here, no limbal ischemia. See, the limbus looks normal, all kind of nice and juicy red out here. Here we think of a red eye as something bad, usually in ophthalmology, but here in chemical burns we like to see kind of a red eye because that means that these blood vessels are patent and working. We've got some epithelial damage here, epithelial defect, should heal nicely. Okay. Grade 2, there's some corneal haze, the iris details are visible, there's some limbal ischemia, but less than half, so less than 6 diopters of limbal ischemia. So here's a grade 2. There's haze here, but we can still see the iris pretty well in that area. And there's some limbal ischemia. These are not normal, kind of good, healthy blood vessels down in this area here. And there's a big epithelial defect and probably goes down to that area too. That'll probably be a grade 2. Grade 3, total corneal epithelial defect, hazy cornea with iris details obscured. You can see some of the iris details, but they're not great. And about 6 clock hours of limbal ischemia, give or take. So perhaps something like this. It's hard for me to tell if there's a total epithelial defect, but big epithelial defect. The iris details are obscured here, and we've got, probably about 6 hours of limbal ischemia here. I want you to look at these blood vessels over here. Think, oh, those are, pretty good-looking blood vessels. However, if you do higher mag on those blood vessels, you can actually see that they're segmented. So these are individual red blood cells that we're seeing here, more or less, and it's just not flowing normally. We shouldn't see that area there. And these are just clogged. So even though you see, oh, yeah, we've got blood vessels here, these blood vessels are like a traffic jam. They're not flowing there. They're not bringing nutrients. And basically, they're not functioning properly. So this is all kind of limbal ischemia. This whole area here, even though it looks red, you'd say, yeah, but this is all limbal ischemia. This is a bad prognostic sign here. And then grade 4 in the Roper-Hall classification is the worst. The cornea is opaque. The iris details are pretty totally obscured and more than 6 hours of limbal ischemia. So there's just a bad alkali injury. All right. So here, in one of my questions earlier, I said something about a white eye. Well, this eye looks white. Isn't that good? We like a white eye. Not in chemical injuries. This is terrible. Okay. Here, there's no epithelium, no good light reflex, can't see the iris at all. Totally white, totally ischemic, and this eye was eventually enucleated. Okay, now the Dewar-King classification is a more recent classification. It's involved in more research studies because it just breaks things down a little bit more. Harminder Dua, one of the authors of this, was a cornea fellow at Wills early in my career, and he's head of the ophthalmology department in Nottingham, England. So anyway, this just to show you just a different classification, 1, 2, 3, 4, 5, 6. And basically it looks at limbal involvement, none, and then by clock hours all the way to total, and then conjunctival involvement, none all the way to total. So it's similar, just if you're a lumper or a splitter, you can break it up into 4 or 6 divisions. On to treatment. The initial goals of treatment are to get the conjunctiva and the cornea to reepithelialize. Right? And one of the ways to do that is to decrease inflammation. I mentioned earlier, we know that inflammation just impedes healing. When it decreases inflammation, get the cornea to heal. Okay? At the same time, you want to correct any eyelid abnormalities. If you've got a burned eyelid that's just not healing well, or the eyelashes are turned in, or there's ectropion or something like that, it's just not going to heal very well. Want to manage glaucoma. All that inflammation can cause glaucoma. And then there's also a setting where the chemical injury actually just kind of shrinks the entire sclera. So it's like you're pressing on a balloon and just increasing the pressure in the eye. So that can raise the pressure too. And of course, you want to prevent infection. You have an epithelial defect, conj or cornea, you have an opening in, you don't want any infection. How do we do all this? Well, we use antibiotics. Frequent ointment is typically what we use. We can also use drops. You want to consider a bandage contact lens. It may be helpful in some patients with epithelial defect. In general, I like to use ointments, but if I use a bandage lens, then I'll change the ointment to drops, just because a bandage lens and ointments don't work very well together. And then anti-inflammatory medications. As I said earlier, inflammation is one of the biggest kind of enemies of healing at this point. These chemicals cause mild to absolutely severe inflammation. You need to use anti-inflammatory medications. We're often taught as residents, if there's a scratch, an epithelial defect, you do not want to use steroids because it'll impede the healing of the scratch. And while that may be somewhat true, here the benefit of decreasing inflammation far outweighs the downside of perhaps slowing down a little epithelialization. So typically we'll use steroid ointment. Again, you can use drops. But there's, Tobradex, for example, is a steroid antibiotic ointment that combines a reasonable antibiotic, excellent steroid, in an ointment form. So you're really kind of killing 2 birds or 3 birds or whatever with one stone. Prevent infection, decrease inflammation, and then lubrication to help the epithelium. You want to use frequent antibiotic steroid, but certainly steroid for the first 1 to 2 weeks. Okay? After the first 2 weeks, we try and decrease the steroid because at that point, the steroids may be doing more harm than good. That's where kind of the reparative phase of the cornea comes in, and the steroids may actually impede that. And you may have a higher chance of stromal melting, ulceration, perforation if you're continuing steroids for longer than 2 weeks. We sometimes change the steroid from something like dexamethasone or penicillin or Predforte to medroxyprogesterone, which is Provera. It's not commercially available. You have to get it made up. The Wills Pharmacy will make that up because that's a fairly potent steroid, but it doesn't impede the healing as much. It's off-label, but it is available for certain chemical injuries. And of course, you want to prevent infection. We sometimes use anti-collagenase medications. Collagenases are these enzymes that come in to break down collagen. Well, the cornea is basically collagen. When these collagenases come in, it just eats away at the collagen. So we want to decrease that. You can do that with tetracycline. We'll often start these patients on doxycycline, tetracycline, and minocycline. You can do it with vitamin C. It's pretty high-dose vitamin C. Some of the recommendations out there are 8 grams a day. I mean, a lot of people think, 500 or a gram if you're sick or something. Some of these recommendations are 8 grams a day. You can also use vitamin C drops, which our pharmacy will make up, and then acetylcysteine or mucormyst is another anti-collagenase, and the pharmacy will make up 10% drops of that too. Now, amniotic membrane tissue. Amniotic membrane is just what you think of. It's the amniotic membrane that comes after a mother delivers a baby. You can take that tissue, and it actually has significant healing properties. There's commercially available several different types of amniotic membrane that we use in corneal problems all the time. It has both anti-inflammatory and growth-promoting properties and probably some antibiotic effect in there too. There's Procara, which is on a ring. There's also Ambiodisc, which is kind of just a disc of amniotic membrane that gets put on the eye, or you can actually take a big sheet of it, put it on, either suture it or glue it in. And what we've learned over the past 5 to 10 years is AMT is extremely helpful in patients with severe chemical burns. And oftentimes we delay. We say, a few weeks go by, they're not healing. Well, let's do AMT now. 2 or 3 or 4 weeks have gone by. Now is the time to do it. We've tried everything else. We're moving much closer to doing it at the beginning of these injuries, in the first day or two. And both Procara and Ambiodisc are things you can have in the office. You can pop it on right while the patient's in the office in the chair. And earlier is probably rather than later is better. Probably earlier is better than later for a lot of these injuries. Obviously, you have to go to the operating room to do one of these sutured or glued grafts. That takes a lot more doing, but some of these things you can do right in the office. So let's just go through what we do for these injuries. For a mild injury, I would use some antibiotic ointment or drops. Cycloplegia, decrease the inflammation, treat any elevated intraocular pressure, and they've got a big scratch probably. You can use oral pain medications. For mild chemical injury, you probably don't need steroid drops for this patient. There's not that much inflammation going on. For moderate, however, here I would add an antibiotic steroid combination such as Tobradex, or if they're already on an ointment and you want to add a steroid drop, that's fine too. But the Tobradex ointment just works very well because it's just one medication, a lot easier for patients. I might add doxycycline or vitamin C, and I might use a bandage contact lens depending on the epithelial defect and the patient. So here's a patient with an alkali injury here. That's a moderate one, and that's where you'd be doing some of these additional treatments, and they have a big epithelial defect. It's a patient with a 1-week status post, an alkali injury. You can just tell it's not healing very well. This is a week has gone by, and the cornea is still very hazy, epithelial defect not healing well. That's that same patient, big epi defect, and the conjunctiva is also a big epithelial defect there. And then if you go up the next step, just severe chemical injuries, we're adding things like acetylcysteine, 10%, which is a mucor mist that the Wills Pharmacy will make up. We think about using vitamin C drops or citrate drops some people will use, and think about adding systemic steroids. Prednisone, 60 or 80 milligrams a day may be helpful. Having said that, these severe chemical injuries, some people take a nihilistic approach. It doesn't matter what you do. These eyes are all going to do poorly. Doesn't mean we shouldn't try, and I think we should, but this is, patients kind of need to know at the beginning if they've got a severe chemical injury. We'll do everything possible, but, this is bad news. And again, seriously consider an amniotic membrane graft, especially early on in these patients. I think that gives us some of the best, that's the best, newest treatment we've got in the past 5 or 10 years for chemical burns. This provides a matrix for the epithelium to either grow on top of or grow underneath. And helps decrease inflammation. And again, we've got these couple different forms, one right in the office or one in the operating room. The ones in the office you can use, one of them is Procara, made by BioTissue. It's basically a 16-millimeter plastic ring that has the AMT just kind of secured to it. So the ring goes in like a contact lens, and the AMT just then sits right up against the cornea. It's expensive, about $900. There's also something called AmbioDisc, which is a disc, about a 14-millimeter disc that you put on and put a contact lens on top of it, less expensive. Whether it stays in as well is a separate issue. Just to show you a couple pictures, this is what the Procara looks like. It comes in this foil pack, and there's the ring. And then the AMT is kind of draped on top of that. It's pretty invisible there. Just to show it in a patient of mine, Procara in the eye. So this patient with not a chemical burn patient, but a chronic epithelial defect patient I was using it in. And there's the edge of the ring here and up here. If the patient looks down, there's the edge of the ring, and the AMT is just draped over it. Same thing here. You can see the edge of the ring over there, draped over. And this ring can stay in for a week or 2 or 3, and then that AMT sits there. Eventually it'll dissolve. Sometimes it dissolves in 2 days. Sometimes it'll last several weeks. Depends on the enzymes and inflammation and things like that, but it can be very helpful. There's just another one I did recently for a patient with a poorly healing defect right there. Now you can also go to the operating room and either suture or glue the amniotic membrane. You can use a variety of sutures, 8-0, 9-0, 10-0, or fibrin glue to secure it to the eye. And that basically works well to help an epithelial defect. And you can use it kind of right on the cornea and then have the epithelium grow on top of it, or you can just use a big piece and have it act like a big bandage contact lens where the epithelium grows underneath it. So these are 2 different ways that it can work. This is a patient of mine with a chronic, painful bullous keratopathy. So chronic corneal swelling, edema, bullae. Normally they would get a cornea transplant, except this eye has essentially no vision potential. We're not going to do a transplant on that. So we sutured the AMT on there, just a big 12-millimeter circle, bunch of stitches. This is post-op day 1, here and here. This is post-op day 9. Epithelium is growing on top of it. It just puts a matrix on there, and then that healed up over the next week. This patient here has 3 weeks post-op. You can see the AMT is still there, but it's kind of shredding a little bit. The epithelium has not grown on top of it, so I wasn't that happy with that, and it's starting to melt away. So then I kind of moved it over a little bit and realized that the epithelium had grown underneath the AMT. It had acted like a bandage contact lens. Epithelium had grown underneath it. When we took all the AMT off, the epithelium had healed completely. So it can work either of those ways, either on top of the AMT or under the AMT. This is a patient who had a chemical burn that was melting away, and an AMT is here just 5 days after, kind of getting epithelialized. Other things to consider in severe injuries, breaking the symblepharon. They all get all kinds of conjunctival scarring there. Some people believe you kind of go and break those. You can help. Unclear whether that really helps. There's also symblepharon ring, which is like this 20-millimeter plastic ring that you can put in there to keep things open. Unclear whether that helps. But you certainly want to correct any eyelid abnormalities, whether you find them early or late. If you have kind of chronically poorly healing epithelium, things to consider: bandage lens, temporary tarsorrhaphy, where basically you suture the eyelids closed just to get the surface to heal, and then, of course, an AMT we already talked about. If they've got a lot of collagenases, epithelial defect, they will eventually end up with melting. And that's just going to happen. Unless that epithelium heals, that cornea will eventually melt. If you've got corneal melting or impending corneal melting, you can try tissue glue, putting a little bit of cyanoacrylate, basically medical-grade super glue to fill in melting areas. Sometimes if they're melted so much that there's a hole there, a small patch graft or a large graft. You may consider a limbal stem cell graft, where you take limbal stem cells, ideally from the fellow eye, and put it in to get good new epithelium to grow in. But you'd like to do that before you've got any significant melting. And a lot of these patients get dry eyes. Their conjunctiva is damaged. Their lacrimal glands are damaged. How do we deal with that? Well, we deal with it the way we deal with severe dry eye patients for other reasons. Gels, drop ointments, Lacrocerts are little kind of collagen pellets that you can put in the inferior cul-de-sac, and then they kind of dissolve over the day and put this kind of gel coat there. Cyclosporin, Restasis can be helpful in some patients. Punctal occlusion, whether it's plugs or cautery, can be helpful. Autologous serum. We work with the University of Pennsylvania, where they will draw the blood. First, they'll take blood tests to make sure patients don't have any infectious diseases, hepatitis, HIV, and then they'll draw the blood, send it off to Leiter's Pharmacy in California. Leiter's will then centrifuge the blood and then just collect the serum. And typically we use between 20% serum to 50% serum with preservative-free tears. They put it in a bottle and then mail it to the patient, and then they can use basically their own serum tears, which has all kinds of goodies, growth factors, antibodies and things like that, that will hopefully help the surface to heal. That works sometimes. The lateral tarsorrhaphy, again, closing the eyelids partially to decrease exposure, can also help with dry eyes. And again, long term, there's damage inside the eye, and you have to monitor for glaucoma. Eyelid problems, short term, obviously, but long term, they can get cicatricial scarring that occurs, especially under the eyelid, that causes causes trichiasis or causes abnormal eyelid position. And if you don't correct that, your cornea will never heal well. And sometimes you've got such severe conjunctival scarring that you need to rebuild the conjunctiva, either with something like amniotic membrane or with a buccal mucosal graft from the mouth. Okay, so here's a patient, has a pseudopterygium, so had inferior scarring down here, healed up with this pseudopterygium 2 years after chemical injury. Not a bad result. Okay? This is nice and stable at this point. It's not perfect, but the body's healed itself. Central cornea is clear, good vision. Comfortable, not a red eye. Now for limbal stem cell deficiency, we're basically around the cornea, 360 degrees, there are these stem cells that create the good corneal epithelium that grows in. In chemical injuries, those are often damaged, and you do not get good epithelium to grow in, and sometimes you don't get any epithelium to grow in. If you have a partial area, so let's say you've got the top half of the cornea that's got poor epithelial stem cells, then what will happen is the conjunctival epithelial cells will grow over the surface and then cause a problem. If you've got an entire cornea that has no stem cells, then you have a bigger problem. So here's a patient who, after an alkali injury, has this abnormal conjunctival epithelial cells here. There's no scratch, but there's abnormality here. And you can see it stains. It's not normal corneal epithelium. And if it goes into the visual axis, it can significantly affect the vision. Here's another area of abnormal limbal stem cells from up here. These grow from the periphery to the central part of the cornea. These are good stem cells here, or good epithelial cells from good stem cells inferiorly, and this is like a little battle line here. Good ones down here, bad ones up here. But if this bad area is in the visual axis, it'll affect the vision. So what you can do if you've got a relatively small area of bad cells, you can do what's called selective epithelial debridement. Where at the slit lamp, you can remove those bad cells and then allow the new good cells to kind of repopulate that area. So just a schematic here. Let's say you've got these abnormal cells coming from up top. You debride that area. And then what will happen is the good cells from down below will grow up, but you haven't fixed these stem cells, so they will still repopulate somewhat. However, you've cleared the visual axis. The vision will be much better here. And they might want to stop and say, I'm done. But you can also remove those cells and have them see them back a week later. And you've just got a smaller area here. And you can even remove those cells and see them back. And at this point, it'll take a while for these cells to kind of repopulate the badness and give poor vision. So I have some patients where I do this, every couple years. I will debride them, and they'll look like that, and then eventually that. When they get back to this point, I'll debride them again. Just a couple of schematics of patients who have had this partial limbal, selective epithelial debridement. So this is a patient with chronic limbal stem cell abnormalities from chronic contact lens wear, not a chemical burn. But they have keratoconus. There's that keratoconus nodule there. Preoperatively, abnormal and normal down here. Moved the nodule, moved all of that. And 7 weeks later, a little bit of scarring here, but beautifully smooth cornea. There's another patient who had multiple surgeries up here, damaged those stem cells, these abnormal areas going down into the visual axis. Post-op day 1, post-op day 11, a little bit of abnormality up here, but still the central cornea looks nice and clear. And there's a patient with numerous surgeries, including this corneal transplant, abnormal cells. 2 days after debridement, central cornea is nice and clear. Then lastly, this is just a chronic contact lens wearer. Little tongue right down here into the visual axis, causing 20/60 vision right there. Immediately after the debridement, 3 days later, nice and smooth, back to 20/20. Now, if you have extensive limbal stem cell abnormality and you have no kind of good area to help populate it, then you need a limbal stem cell graft. Ideally, you can take it from the uninjured fellow eye, if in fact they have an uninjured fellow eye, and if the patient will let you touch their good eye. Some people have a chemical injury in one eye, they consider their bad eye. They will not let you anywhere near the good eye to take cells, which is fine. You can get them from a cadaver or from a relative. But if you get it from a relative or a cadaver, then you need systemic immunosuppression. You need steroids, you need Cellsapt or Cytoxan or something, cyclosporin, systemically to decrease the chance of rejection. This is a patient who's had a week after a limbal stem cell transplant, so up in this area and this area here, limbal stem cell transplants to try and get the surface to heal. Once you get a good surface, you can then do a full-thickness corneal transplant to try and get you better vision. If you do a full-thickness transplant without good surface cells, that transplant is guaranteed to fail. The long-term treatment, what do we do for corneal scarring? Well, sometimes if it's mild, you can get away with a soft lens. If it's more significant, a rigid gas perm lens, maybe excimer laser PTK. Maybe you can shave some of that down a little bit. Maybe a full-thickness transplant, but it may require a limbal stem cell graft to prepare the surface. And sometimes a permanent keratoprosthesis can be done. You may need a lateral tarsorrhaphy or something, but keratoprostheses in bad chemical injuries just do not work all that well. This is a patient I showed earlier, just some mild damage here, 6 weeks after an alkali injury, not doing poorly. Here's just to show a bunch of pictures of some injuries. This is years after an alkali injury with significant scarring and irregularity here. Amazingly, this patient did fairly well with a rigid gas permeable contact lens. This is just years after an injury, significant scarring in that area, but nice and stable with a quiet eye, but not very good vision. And this is a year after this patient with a chemical injury. You can still see there's just this hyphema that's basically stuck in the cornea. It's an intracorneal blood here with inflammation. And then 2 years later, so 3 years after the injury in the same eye, that blood has all gone away with scarring, but you can see that it actually had caused so much damage it separated decimase. That's a decimase detachment there from the chemical injury. And there, just to show you that this is an acid injury, okay, we think of them not so bad, but this is bad. And here's after an alkali injury. So this patient here underwent a keratoprosthesis for this, I'm sorry, that should say alkali injury, because this is the same patient. It's alkali injury there, and that's the K-pro for that same injury, and this patient actually was doing fairly well. And here's a patient who had a cornea transplant for a sulfuric acid injury. So there's the clear cornea, and there are the little areas of where the stitches were, caused some inflammation, and gets remarkably good vision through that relatively clear central cornea. And this is years after an alkali injury. Maybe hard to tell you, but this patient did have a cornea transplant and did not do well, obviously. That patient went on to get an alpha core, which is a type of a keratoprosthesis, an artificial cornea we were using about 15 years ago. This is my patient, but this did not give him much better vision. So he went on to a permanent Boston keratoprosthesis and actually got 20/40 vision out of this eye. Hadn't seen this well in 20 years. That lasted for about 2 years till he got end-stage glaucoma and basically went blind. Even though we were following him all the time, he was seen by the glaucoma docs all the time, every month we were following him, but the problem with these permanent keratoprostheses is it's very difficult to check the pressure. You have to check it with your finger. We think we're doing okay. He's on meds. He already had a tube shunt, yet went blind from glaucoma. So that's quite sad. Okay, so basically, there's excellent prognosis for mild injuries. So the Roper Hall DUA grade 1s, fair to good for moderate injuries. The Roper Hall 2-3, DUA 2 to 4, but poor to dismal prognosis for the Roper Hall 4s and the DUA 5 to 6s. That's just the way it is, no matter what you do. Here's just 5 years after an alkali injury in both eyes, right eye and the left eye in that patient. As a patient I saw not that long ago, what do you think of that? Good or bad? Bad. It is bad. Cornea looks, you say, oh, it's pretty clear. He actually, the problem sometimes with some of these patients is when they come in, he sees okay at the beginning. He sees through that because there's big epidefect, but it's fairly clear. But this limbal ischemia is 360 degrees. It's bad. There's what it looked like. This is a while after the injury, actually. It has some conjunctiva epithelialization up here, but it's not getting any better. Not getting any better. This superior area up here never healed. This is a big epidefect that went all the way to the upper lid, and it got worse and worse and worse, and eventually he just asked for an evisceration. Okay, back to the questions. Regarding chemical injuries, which is true? Acid injuries are more common but generally less severe than alkali injuries. Is it true or not? No, they're not more common. B, alkali injuries almost always cause severe vision loss. No, not almost. There can be mild alkali injuries. They're not almost always. A white eye in presentation is a good prognostic sign. No. It's safe to use steroids in the initial treatment of chemical injuries. Yes. Okay? That's one thing that many people are just afraid to do, but in fact, not using steroids in some of these severe injuries makes them worse. Okay, that was the right answer. 2, upon arrival, the chemical burn patient in the ER, an extensive history should be taken. No. The vision should be checked immediately. It's a little, correct. No. But, I wouldn't fault someone to take a quick vision, spend 2 minutes, but okay. The pH should be checked before irrigation. Yes. Good. Irrigation of acid injury should be done with alkali and vice versa? No. Okay. pH should be checked to irrigation. Last question. Treatment of chemical injury. AMT should be considered early in the treatment of severe chemical injuries. Yes. A bandage that should be used in all patients with epithelial defects. No, not necessarily. It's okay. Paracentesis and wash of the AC significantly improve the prognosis. No. Permanent K-pros work well for corneal scarring. Not in these patients. These chemical burn patients just don't do well with these. So in conclusion, chemical injuries are common. They're potentially blinding. Emergent treatment is helpful. Initial antibiotic and anti-inflammatory treatment, such as steroids, helpful. AMT may be very beneficial early. Having said all that, some eyes do poorly no matter what treatment is given. Thank you very much. Questions? We have time for questions? We have a couple of seconds for questions if anybody has any. Yes? Some of the blood vessels growing on top of that white cornea. Well, one of those pictures just showed basically conjunctival scar tissue kind of coming right over. I'm not sure if that was it. But we certainly don't want blood vessels in the cornea. Having said that, blood vessels with a solid, well-healed cornea is better than no epithelialization where it's guaranteed to melt eventually. Yes? I'm sorry, louder? Yes. The efficacy of the amniotic membrane is dependent on whether there are good stem cells. If you don't have good stem cells, an AMT does not bring in stem cells. Right. But if you have some damage to the stem cells, but you've got other good ones there, an AMT can decrease that inflammation, help with the healing, and help improve the prognosis. Elam. It depends on the patient. So those are not usually the chemical burn patients, but the other patients I showed, some of those patients, the abnormal stem cells are just not so terrible, and it might be years before you need to do anything, if ever. And sometimes they're so abnormal, they grow in very quickly, and 6 months later you need to debride them again. Yes, Maria. Insurance does pay for AMT, but most insurance pays for AMT. In our office, before you can go to the freezer to get it, you have to check with our billing person, and they make sure it'll be covered, because it's $900, and you've already paid for it. It's in your fridge. You've bought it, and if you give it out and there's not insurance, the chance you're getting that money back is low. Yeah. Any other questions? Thank you very much.